right. Hello, everyone. Welcome to the 2023 PI conference. So I'm just gonna give us about 30 more seconds and wait for everyone to join, but we'll get started in just a moment. We're very excited to have you. Alrighty, so I think we can get started here. So, hi everyone, my name is Mara Tui, and I will be your moderator for today's session, Selective IgA and IgM. I am very excited to welcome Dr. Gupta here with me, who will be presenting this topic. There will be time for questions at the end of the presentation, so please make sure to submit any questions you have to the presenter in the Q&A section of the platform. So before we get started, I want to go over a little bit about Dr. Gupta here, who again, we are very happy to have with us. So Dr. Gupta is a professor of medicine and established new division of basic and clinical immunology. Currently, he's a professor of medicine, pathology, and laboratory medicine and microbiology and molecular genetics, and the chief of the division of basic and clinical immunology. Director of Research, Director of the Jeffrey Modell Center for Primary Immunodeficiencies, Director of Program in Primary Immunodeficiency and Aging, member of Institute for Immunology and Cancer Research Institute at the University of California, Irvine, which, as you can see in his wonderful background, he has up today with us. He has received numerous awards, including Doctor of Science from King George's Medical University, the Lifetime Achievement Award from the Jeffrey Modell Foundation, the Mastership of the American College of Physicians, and most recently, he was elected as Fellows of Royal College of Physicians, London. Dr. Gupta has served on committees of the National Institutes of Health, Food and Drug Administration, and Advisory Committee to the World Health Organization. He is the founding editor of the Journal of Clinical Immunology and served as its editor-in-chief for 3 decades, since 1981. He has published more than 630 scientific papers, invited reviews, and book chapters, and he has edited 31 books, including a book on primary immunodeficiency with Claude Grischelli, and a book on innate immunity with Ralph Steinman. In recognition of his scientific contributions to immunology and to the University of California, Irvine, the president of the University of California has established an endowed chair in his name, Sudhir Gupta Endowed Chair in Molecular Immunology. In 2010, Dr. Gupta founded a not-for-profit and charitable foundation, the Foundation for Primary Immunodeficiency Diseases, which you can find at www.fpid.org, with the mission to support education of patients, clinicians, and scientists, early diagnosis, treatment, and research for primary immunodeficiency diseases in India and the US. Its International Scientific Advisory Board comprised of 2 Nobel laureates and 4 members of the US National Academy of Sciences and a pioneer in gene therapy. There are 9 FPID centers in various medical and research institutions around India. So if everyone could join me in giving Dr. Gupta a very warm welcome. Thank you so much for joining us. And now I will be passing off the presentation to you, Dr. Gupta.
Thank you very much for that kind introduction. Let's see. We get or I think we should be okay. Everybody can see the slides?
Yep,
Okay.
you can see your screen. You're good.
Yeah, you can see the slides, right?
Yep, we can see it.
Okay, thank you very much for inviting me to speak. At least one of those topics very close to my heart. These are my disclosures. Let me see if I can move this thing up. Okay, this is the outline of presentation. So I'll briefly tell you about each IgM and IgA, characteristics of these 2 molecules. What's the prevalence of these two deficiencies, what we know about the genetics, what are the common clinical features, in brief, immunological feature, how we diagnose them, and what our treatment options are. So as most of you know, interested in primary immunodeficiency diseases, currently we have more than 485 different primary immunodeficiency diseases. Since all of them don't have the immune deficiency, so the terminology is now slowly changing to inborn error of immunity, because there are certain primary immunodeficiency of inflammation or autoinflammatory diseases don't have the deficiency of the immune system, but more of excess. Then there are immune deficiency of regulation of the immune system, so-called dysregulated primary immunodeficiency diseases. And therefore, slowly, this terminology of PID or PIDD will transition into inborn error of immunity. Whether that terminology is appropriate or not, one can always discuss those. And there are more than 400 pathogenic or disease-causing genes which have been discovered assigned to various primary immune deficiencies. Even though those 485 different primary immunodeficiency have been classified under 12 different categories, but the old classification for the practical purposes is still perhaps the best one, that you have one group of combined immune deficiency, other group is of antibody deficiency, third group of neutrophil immunodeficiency or phagocytic cell immune deficiency, and the fourth is the complement immune deficiency. So if you remember those four, I think you cover 90% or 95% of primary immunodeficiencies. So among all these deficiencies, antibody deficiencies are the most common. They make almost 60% of all the primary immunodeficiency disease. Selective IgA deficiency is the most common primary antibody deficiency, regardless of the age. So if you take from children to adult, that's the most common one. In adult, it is the common variable immunodeficiency, which is the common. Then you have the selective IgM deficiency, which is one of the, at the moment, considered as one of the rarest ones, but it may not be the case. So there are certain features which are common to both of them, and those are the ones that I will discuss with you. And in majority of the individual, both selective IgM deficiency and IgA deficiency, majority of the patients are asymptomatic. Those who are symptomatic, they commonly present with infection, and among the infection, most common presentation is the sinopulmonary infection. Allergies and autoimmunity is fairly common, almost 20 to 30% of these patients. We will discuss them. And often, when infection is not the presenting manifestation, patient could be diagnosed, but in the allergist office or in some of the rheumatologist office. Rarely, each of these disorders can progress to common variable immunodeficiency disease. So when you look at the IgM, of course, there is all the immunoglobulin are on the surface of the B cell, but the most important, the biological function they impart is due to circulating or the immunoglobulin that are on the mucosal surfaces. So IgM is almost entirely in a normal status, is a circulating immunoglobulin. In case of selective IgM deficiency, some of the IgM could be in the secretion to compensate for that lack of mucosal IgA antibody. But IgM antibody is the first antibody that is produced when we get infection for the first time, or we give vaccine to ourselves or everybody else. So exposure to an antigen that doesn't belong to us, either by natural means or through vaccine, IgM is the first immunoglobulin to be synthesized and produced. It makes about 10% of total immunoglobulins. As you know, immunoglobulins are IgM, IgG, IgA, and IgE in the circulation. And IgM, IgG, and IgA are the one which makes most and majority of the circulating immunoglobulin, or as well as in case of IgA, a secretory immunoglobulin. It has a short half-life of 5 days, as opposed to IgG, which is between 3 to 4 weeks. Now here you see the difference between a serum IgG and serum IgM. So as you can see, it's just like a Y structure. And this arm of the Y is the one that will bind or respond to a microbe or to a vaccine for that purpose. And this is the portion of the antibody, which is very important in neutralizing the microbe or their toxins. Whereas this tail portion is the one, it mediates a lot of either anti-inflammatory or normal amount of inflammatory, and it helps number of cells of the immune system to work effectively. Now, if you look at this picture of IgG and IgM, you can just think about it. You are putting 5 of IgG together and join them with a joining chain. So IgM becomes a very large immunoglobulin, very large molecule. And perhaps why it is produced, nobody knows for sure, because immune system wants to conserve energy. And so if you have number of bacteria or other microbe viruses, if you have a molecule which has these binding site or neutralizing site to the microbe, instead of one, these two in IgG, if you have 10 of those, you can work very effectively. So initially, immunoglobulin is produced, which will be highly effective that way. Now, IgM comes in 2 flavors. One is that it doesn't require stimulation by a microbe or by a vaccine. So it is called the natural IgM or pre-immunized IgM, and it is spontaneously produced our B cells. And the second one is where those B cells, that's IgM, come in contact with a foreign antigen, whether it is a microbe or the vaccine, otherwise, and therefore it is adaptive. It is adapting to the exogenous antigen and producing an immune response. So it is called as an adaptive or immune IgM. So the difference between a natural IgM and adaptive IgM are following. Natural IgM have 2 important features. It is polyreactive and autoreactive. That means it will react to our own tissue in certain stage, not in a normal stage. And secondly, it is polyreactive. That means it can bind to a lot of other structures which may be present on the microbes or otherwise, and therefore they can be really a defensive against number of antigens. And since they are spontaneously produced, they are produced in response to our own tissue antigen. And that's why this autoreactivate. And one can always, and let me see if I can move this thing somewhere. How can I move there? I don't know. This thing, you're not seeing that. Okay. Let me see what's happening. What happened?
Are you looking for your pointer? It's in on the right
Okay.
of the screen.
Okay, I'm just trying to get this bar down, which I don't know how to do it. It's coming on my screen, but it's not your screen, right?
We can see it.
You
Yeah,
can also see.
You mean your laser pointer? Yeah, we can see it.
No, there is just a line. Okay, so it has a role in protecting. As I said, natural antibodies are produced in response to self-antigen. And so every cell in our body comes equipped to die at certain time. And you can imagine when that cell dies, it releases all the self-antigen. And if those dead cells or the self-antigens are not removed, we can have a lot of autoimmunity. So the role of IgM is to clear those autoreactive or apoptotic body, the cells that have died by a process of a programmed cell death. So those are the dead cell which carries the self-antigen and therefore can induce both inflammation and autoimmunity. And so IgM removes that. So major function of natural IgM is to protect from autoimmunity and inflammation. It has some role on microbial defense, but the immune IgM is the one because it has produced very specifically in response to infection or a vaccine. And therefore, it has a major role in protection against microbial infections. It does have some role in autoimmunity as well, but that's the major role. I don't know why. Okay. So in microbial defense, its role is that it protects against viruses, bacteria, fungi, and protozoa. So broad spectrum of microbes that it plays a defense role. And as you can see on this slide, some of them, a natural IgM has a major role as opposed to the immune one. But the fact is that IgM total, I do not care how much, whether it is natural or immune. So far, I have the immune as well as natural IgM. I'll be protected against various microbes. Now, selective IgM deficiency, although described in 1968 by John Hobbs in two children, one suffering from meningitis, this particular deficiency was never given very much significant to it. It was not until 2017 that International Union of Immunological Society recognized it as a primary selective IgM deficiency. So now it is a bona fide one of the primary immunodeficiency diseases. It is still the definition somewhat arguable. However, we very clearly define it that if patient has less than 2 standard deviation below the mean of age-matched control with a normal total IgG and IgA, and when secondary causes or other primary immunodeficiency that are associated with low IgM have been excluded, then only you make the diagnosis of selective IgM deficiency. The prevalence again varies, as you can see on the top, 0.03 to somewhere 0.37 in the screening. And this might have to do with the population studied, what really the criteria was taken. But to say that still it is a rare primary immunodeficiency disease. There's no gender preference. Both men and women are affected equally. As far as genetics is concerned, there's no definite inheritance pattern. There are a number of families now have been described. Originally was described in 1976. We have described mother and daughter, and now currently we have 3 generations of selective IgM deficiency patients. The gene mutation is still, we don't know. There is no pathogenic gene which has been described. There have been just the association that there is one paper for one patient, the BTK, which you know is for X-linked gamma globulinemia mutation has been described. Connexin is another one. The MALT1 is the one that we, in collaboration with Dr. Casanova, has found in 3 generations of this family. Still, we are in the process. And it is a very unique mutation because the MALT1 mutation causes other primary immunodeficiency diseases. Whether that is a pathogenic mutation, we are still testing it. Clinically, as I told you, majority of the patients, about 60% of the patients, will be asymptomatic. And that might be, the number, if we take the total number, it might be underestimated because they are asymptomatic, so they are not diagnosed. Those who are symptomatic, majority of them present with infections, other with allergic diseases and autoimmune diseases. They are fairly common, and rarely these IgM patients present with certain malignancies. In infection, as you can see, majority of the infections are, oh, what happened? Oh. I'm doing something wrong. Okay, majority of the infection, as you can see, are sinopulmonary infection. And so right from otitis media to sinusitis to pneumonia. However, the cases, what we diagnosed, the first case was with a sepsis. So you can have very severe manifestation, originally were described for meningitis. But those are the common infectious manifestation. These are the common organisms that these patients are infected with, which are in the yellow, and top 3 are the most common, and they are not unusual to selective IgM deficiency. These are quite common in antibody deficiency in general. Allergic diseases are common. Allergic diseases are prevalent in 30% of the cases. The rhinitis, asthma, eczema, and angioedema. This is a large group of autoimmune diseases which are common. And among them, if you take the Hashimoto's thyroiditis, systemic lupus, and autoimmune cytopenia, those are the most common of the autoimmune disease. And this shows you that here that 34%, 1/3 of the cases of selective IgM deficiency have endocrine autoimmunity and predominantly the thyroid autoimmunity, whereas more than a quarter of the patients have with a connective tissue disease, where you have the lupus being the most common one. Various malignancies have been described, and these are just the case reports. So it is difficult to make a statement that there is an increased susceptibility or increased incidence or prevalence of malignancy in selective IgM deficiency. We have to have a large number of cases before we can make that statement. For the immune profile in these cases, the natural, in the innate immunity, both the natural killer cell, phagocytic cell, the neutrophil, as well as the complement system, their number and functions are normal. In the adaptive immune response, in majority of the cases, T cell and T cell subsets are normal. By no means, if you find some abnormal subset in one of the patients, you cannot exclude the diagnosis. But in majority of the cases, T cell subset, their numbers, their functions, and the B cells with surface immunoglobulin, they appears to be normal. As by definition, total IgG and IgA are normal, but IgG subclasses, either alone or in combination, could be low. Response to classical vaccine, especially when we test antibody deficiency, we test predominantly for T-independent, so-called Pneumovax 23. In about 2/3 of the cases, those responses are normal. However, in 1/3 of the cases, the response is impaired. And therefore, it is a little different what European Society of Immunodeficiency, in their working definition, made that for selective IgM deficiency, the response to vaccine should be normal, but that's not the case in a real life. We have a number of patients who have 0 IgM and they have an impaired response to these vaccines. And they also, number of these patients will have autoantibodies without clinical manifestation of those autoantibodies. They can have anti-double stranded antibody, still patient doesn't have a clinical manifestation of lupus, or they can have anti-TPO antibody, they still don't have hypothyroidism. The diagnosis, as we initially discussed, have to be made by looking at the serum immunoglobulin that are 2 standard deviation for the mean, for the H-mean control, and a normal level of total IgG and IgA. Those low levels of IgM must be demonstrated at least on 2 separate occasions, at least 2 months apart, that i.e. they should be reproducible. The secondary causes and other primary immunodeficiency with low IgM have been excluded. And again, highlighting the presence of low IgG subclasses or impaired response to vaccine do not exclude a diagnosis of selective IgM deficiency as compared to the working definition. ESID has never came out with a definitive diagnostic criteria. They had the working diagnosis. These are various causes of the secondary IgM deficiency, number of primary immunodeficiency diseases, where you can have a very low IgM, but in cases, the true secondary immunodeficiency you see is in a B cell neoplasm, non-Hodgkin lymphoma, chronic lymphocytic leukemia, plasma cell dyscrasia, that be a monoclonal gammopathy or a multiple myeloma, some of the psychotropic drugs have shown to cause selective IgM deficiency. And these days we are using more B-cell depletion therapy, and Rituxan especially is associated. And again, it depends upon what is the underlying disease for Rituxan given, because the type and the degree of immune deficiency by depleting the B cell by Rituxan varies. So in cases of rheumatological diseases, treating with Rituxan, one can find fair proportion of these patients to begin with will have only IgM deficiency, and as time goes by, they can have other immunoglobulin isotype, even simulating a common variable immunodeficiency disease. But we should keep in mind that there are a number of medication or the diseases that can be associated or with low IgM, and those should be excluded before we make a primary immunodeficiency diagnosis. So how we treat these patients? Of course, those symptomatic patients, you give them, there is no IgM preparation to replace. So we are left with two important approaches to treatment. One is to give antibiotic treatment. In general, all antibody deficiency patients do not respond as well as normal individuals to antibiotics, and therefore requires a much prolonged course of antibiotics. So if patient is getting 10 days of antibiotic, perhaps you might like to give them another week of antibiotics. Those who are symptomatic, who have a specific antibody deficiency and or with or without IgG subclass deficiency, these are the patients, in our experience, have been most benefited with respect to their clinical infection. So we have to be very selective in these cases, that the patients who are symptomatic, who have underlying functional with or without a decrease in IgG subclass deficiency, those will be the ideal patients with selective IgM deficiency, which could be treated. And it is regardless which route you are using it, they equally respond well. Now let me turn to selective IgA deficiency. Selective IgA deficiency, as I told you, this is the commonest of antibody deficiency, and it is present in the serum as well as in the secretion, but majority of it is present in the secretion where it does its defense role. So here you see again, if you take the one IgG molecule, and then you join them together, they become a dimer. But what you see, a unique feature in a secretory IgA, is the secretory component, which is added when the cell from the plasma cell made, and then it is secreted. While it is secreted or transported to the mucosal surface in the secretion, the secretory piece is added. And this secretory piece is very resistant to all our gastrointestinal enzymes. And that's why this is still very, very important immunoglobulin molecule that protects our mucosal surface, as you can see, the entire gastrointestinal tract, respiratory tract, as well as in other mucosal surfaces. If you take just the IgG molecule and you expose them to their pepsin and their papain in gastric juice, it would be all broken down into pieces, and that's why you can't give IgG orally. The function of IgA molecule it neutralizes the pathogen and toxin like other antibodies. It also inhibits the attachment of microbe to mucosal surface. So it is very, very important. Just think about it. If you have a patient with selective IgA deficiency, very, very easily with the COVID coming through the nasal mucosa. If you don't have IgA, you do not have that protection as opposed to normal person. There is also a passive immunity because IgA is transferred through milk and the colostrum in the newborn. It has some anti-inflammatory property, and it is in a symbiotic relationship with commensal bacteria, which are normally present. So we define selective IgA deficiency. This is from a genetic point of view, that it is a sporadic disease, but autosomal recessive as well as autosomal dominant pattern have been reported. The possibility of inheriting the disease in the family is almost 1 in 5. There is very much difference between geographical and ethnicity with respect to the prevalence of IgA deficiency. As you can see in United States, entire North America, you can look at South America. It is around 1 in 500 or so, and as opposed to when you look here, the China, and you look at Japan, Japan is about 1 in 18,000. So there is very much difference in the prevalence. Why it is so, we don't know for sure, but the fact is, in that part of the world, it is extremely, extremely rare. Now, if you look at the genetics, this is one of the genes which is present in about 13% of a patient with selective IgA deficiency. And this mutation, this gene mutation, is also found in common variable immunodeficiency diseases. So this, along with the progression of selective IgA deficiency into common variable immunodeficiency, may suggest there is some common genetic basis of these two disorders. And there's an association also between selective IgA deficiency, and there are certain HLA type which makes them more susceptible to autoimmune diseases. So a clinical manifestation, just like selective IgM deficiency, IgA deficiency patient, majority of them are asymptomatic. The way you know what the prevalence is, because you are doing the screening blood bank donors and you find out that they are lacking IgA. The most common presentation, just like selective IgM deficiency, the infection, allergic diseases, autoimmune diseases, but there are certain malignancies which are much more prevalent in selective IgA deficiency. The infection again is same. Most of the infection are sinopulmonary infections, but where you see the infections in IgA deficiency, those patients with selective IgA deficiency are often also have IgG subclass deficiency, and the most common one being IgG2 and IgG3. They have very similar organisms, you see. These patients, because of a prolonged infection, so before they are diagnosed, they can develop the complication such as bronchiectasis. Allergies are prevalent, and they can manifest just like any other allergies. It is rhinoconjunctivitis, asthma, urticaria, food allergies. Food allergies are much more common with selective IgA deficiency. We have not seen that many with selective IgM deficiency, and that again may be because there is excessive absorption of the food antigen in absence of selective IgA deficiency. There are a number of autoimmune diseases which have a strong association, and these are listed here: systemic lupus, Hashimoto's thyroiditis, type 1 diabetes, and so on. A weaker, but definitely more than general population, one should think about a celiac disease in these cases. And if you think of the celiac disease, in these cases, the gastrointestinal people, they should do the antibodies of IgG class. When we do the TTG antibodies, usually they are done of IgA type, but make sure that you do the IgG antibody because the patient could be completely IgA deficient. And then if you do just plain simple IgA, that would be negative. There are a number of autoantibodies which are present without the disease. The one important to mention is the anti-IgA antibodies. These are commonly present in patients with complete IgA deficiency. However, there's no correlation between the titer of these antibodies and the transfusion reaction. And that is understandable because these anti-IgA antibody that we are measuring are the IgG antibody. So the severe transfusion reaction which takes place is as a result of IgA anti-IgE antibody. So there have to be IgE class of antibody against IgA to put the patient at risk for anaphylaxis or severe transfusion reaction. And unfortunately, there's no commercial test available for it. Still, it is recommended these tests to be done routinely. And then you have, if you look at the risk for the transfusion is uncommon, it's 1 in 30. I would say it is even rare you find that. Malignancies, the B-cell malignancies, especially of gastrointestinal tract, is the one at the top of the list as far as the frequency is concerned in selective IgA deficiency. However, one can have other solid tumors as well. The immune cells, you have the normal NK cells, normal neutrophils, normal complement, normal T cells, and you can have a IgG subclass low, just like in IgM, but here the response to vaccines are normal. And again, you can have a lot of autoantibodies, just like selective IgM deficiency. So the diagnosis you make is susceptible to infection, which is not necessary because in asymptomatic cases that will be the case, but IgA below 7 milligram per deciliter with a normal IgG IgM in a patient more than 40 years of age. So don't make the diagnosis for selective IgA deficiency less than 4 years of age because it is the slowest of the immunoglobulin to reach the adult age. Normal response to vaccine, normal T cell function, and secondary causes have been ruled out. And these are a number of common drugs you see that are used that can induce or produce selective IgA deficiency and number of infections. And there are a number of primary immunodeficiency that are associated with IgA, low IgA or IgA deficiency, complete absence, as well as some of the chromosomal abnormality. Those have to be ruled out. So the treatment option with selective IgA deficiency is the patient awareness and education, especially to prevent potential anaphylaxis reaction secondary to transfusion of blood or blood product. And therefore, patients should wear a medical alert bracelet. There should be a periodic monitoring 4 to 6 months, as some of these patients can progress to CVID. Prolonged and prophylactic antibiotic while you are managing the allergies or autoimmunity, still these patients continue to have a breakthrough infection. In those cases, one could even institute a prophylactic antibiotic, especially in children. Then those immunoglobulin replacement should be very, very cautiously. It should be in selective. It is a patient who are very highly symptomatic, who may have IgG subclass deficiency. And in these cases, the treatment should be with the preparation of the immunoglobulin, which has the minimal amount of IgA. One of the things in our experience, and we have published on this, that if you give a skin test with the preparation that you are going to prepare in a patient, then you might look for immediate hypersensitivity reaction. So we had a patient who was in the first time, usually it is the second or third infusion you get these reactions. And that first time developed anaphylactic reaction and was skin test later on, was skin test positive. And then we could also demonstrate very clearly that it was against IgA. So in conclusion, selective IgA and IgM represent the commonest and among the rarest of the primary immunodeficiency diseases. However, they present very similar clinical and immunological features and also challenges for the treatment option. The majority of the patients are asymptomatic. Those symptomatic present with sinopulmonary infections. There's increased susceptibility to allergic and autoimmune diseases. Awareness and education is important. Regular follow-up and prolonged occasional prophylactic use of antibiotic is appropriate. Immunoglobulin replacement therapy should be used cautiously in selective IgA deficiency and selectively in selective IgM deficiency. These genes remains to be discovered. The gene for, if you look at the risk for COVID-19 in patients with selective IgM deficiency, approximately 4 to 7-fold higher than the general population. And as I told you, IgA is so important in blocking the virus attaching to the surface. There is no increased risk for COVID-19. These are the resources if you want for the families, if you want to find out the physicians or a pediatrician dealing with these. Jeffrey Modell Foundation is the best place. If you are in California, you can come to the Jeffrey Modell Center. These are the few reviews that I have listed there that you can jot down. And since we have about 15 minutes, so thank you very much, and we can
Awesome.
open.
Yeah, thank you so much. Yeah, thank you so much, Dr. Gupta, for that that amazing overview. So we now have some time available for Q&A. So at this time, if you have questions, please send them in through our Q&A through the conference. So before we begin, please remember that everyone's treatment and condition are unique. Oh, let me show my video here. There we go.
Okay.
So before we begin, please remember that everyone's treatment and condition are unique. The information presented during the session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other health provider with questions concerning a medical condition. So we've received some great questions, and again, please keep sending them in. So our first question we're going to start off with is, and this is a good question, if I have selective IgA, should my family have genetic testing done?
They should definitely have a immunoglobulin done. And for primary immunodeficiency diseases, wherever we are suspecting any primary immunodeficiency diseases, what will come down in very soon, within a year or two, that every patient should have a genetic testing done. And if the patient has some evidence, then of course you go to the family that way. So first the patient and then the family.
Yeah, and then our next question is, how does selective IgM compare to hyper IgM?
It is very different, as the name suggests. In one, you are not secreting IgM, whereas in another, you are making more IgM. When our immune cells make antibodies, first antibodies we make is IgM, and that IgM making B cells, then some of those switch to become IgG producing, some will be IgA producing. That switching from IgM to IgG, IgA, or IgE is regulated by certain genes. So if you have the defect of those genes, You don't make any G, A, or E, and as a result, you are very susceptible to infection. So when you are susceptible to infection, immune system will try to fight it out. And what it is going to do, it is only going to make IgM. It can't make G and A. So each time you get infection, you make that, and therefore it becomes hyper IgM. Totally different diseases. But again, just think about it. If you have, and if you are a physician, always remember, if somebody come after first infection, that hyper IgM patient may still have perfectly normal IgM with no IgG or A, because immune system has only one time got stimulated with one infection. So the more the infection, longer the duration of that disease, roughly you'll find much higher levels of IgM.
Yeah, thanks for answering that. So our next question is, can selective IgA and IgM deficiencies eventually result in getting below normal low levels of IgG even while getting IVIG?
What's the question? Could you read me again?
Yeah, I can repeat it. So the question is, can selective IgA and IgM deficiencies eventually result in getting below normal low levels of IgG even while getting IVIG?
Once you get IVIG, you have to stop the IVIG in order to find that they have gone lower. But as I indicated, patient with selective IgM deficiency and IgA deficiency, they can progress to so-called common variable immune deficiency, which will include that your IgG has gone down. But if a patient is on IVIG, you cannot measure it. You have to stop in order to find that the patient has gone to low IgG. Is that the answer?
Yeah. And then, yeah, thanks for answering. And then our next question is, I have no B cells or IgG, IgA, or IgM. I get infusions every 4 weeks, but I still get infections. What else can I do to help?
Very interesting question. So if you don't have no B cells, no IgG, no IgA, and no IgM, there are only two possibilities. Either you have the XLA or you have one of those very severe type of common variable immune deficiency that you have really no B cells and no immunoglobulin that way. In these cases, the very old one, which is not really done, but was very effective. This is what Bob Good and we used to do back in 70s, that the reason you might be getting the infection, one of the reasons could be that in your environment, there are some bugs against which in your immunoglobulin preparation, there are not enough antibody titers. So there are two things to do first. One is to change the brand and see, because the donor pool is different from one to other. So the first thing, if I'm a treating immunologist, I'm going to change the brand first. That's one. And of course, we always look at it. Can we give a little more frequently? Because the amount of immunoglobulin that you require might be much higher than what traditionally given. So always remember, IVIG treatment is really a treatment to keep you free from infection. So the appropriate dose of IVIG is what keep you free from infection. So you want to change or increase the dose, that you can do either by increasing the frequency or increasing the immunoglobulin, or both of them. So if those do not work, along with a good antibiotic treatment, the last one, which is not commonly done anymore, but it was very effective, and that is to take the plasma that your family members who lives in an environment they donate the blood and you prepare the plasma from there and give. Therefore, you can have a really very specific antibody titers to that environment.
Yeah, very interesting. And this may be our last question that we have time for, but the question is CVID with low IgG and IgM considered combined immune deficiency?
Combined immunodeficiency is that you have to have a combination of the two immune system. So just having two component in the one immune system is not the combined immunodeficiency. So if you have the T cell also a problem, then you will call them as a combined immunodeficiency. So you have to have both T and B cell defect.
Great. And then actually this will be our final question. So this is a really interesting question. So they say my diagnosis is CVID, but would it be possible that I had selective IgA deficiency before having CVID?
It is very difficult to say that. It is very, very difficult. But there are a number of other features that one could look at it. If those are present, they will go in favor, because in cases of selective IgM deficiency, the switch B cells are decreased, as well as there is another cell, which is the low CD21 positive, they are increased. But again, we have not studied, I don't think there are good studies looking at those small proportion of those selective IgA patients who progress into IgM, whether they also develop those changes. But I think it will be not in too long distance future. We'll have the genetic studies done wherever you suspect a primary immunodeficiency before you will get T and B cells done.
Yeah, very interesting stuff. So at this time, our time together has come to an end. Thank you so very much, Dr. Gupta. It was a pleasure. It's been an honor to have you join us today. So this session is one of 39 unique learning opportunities provided through our 2023 PI conference. We hope you continue tuning in today as we explore other critical topics for the PI community. And if you have any other questions for the Q&A, we please advise you to submit them through Ask IDF. So thank you again, Dr. Gupta.
You're most welcome. Thank you for having me.
Thank you. Have a wonderful rest of your day, everyone.
You too.